Hi, everybody, and welcome. Thank you so much for coming out on this very cold night. I hope everybody had a good Thanksgiving. I'm Dr. Laura Lieberman. I'm Director of the Office of Faculty Development. And tonight, this is part of our student seminar series. So we have quarterly lectures, so 4 a year during the school year, to talk about topics relevant to oncology, health, medicine, science. We welcome students, high school students, college students from the area. And our goal in this is to create a learning community consisting of students and staff at MSK who are interested in these topics. So just so I get a sense, how many of you are in high school? Great. How many in college? How many just came for the pizza? Okay. There's going to be a little leftover pizza, so you can check it out on the way out. I'm sorry, somebody say something? No? Okay. Today we're going to hear about from NASA to MSK exercise oncology. Before I tell you a little bit about that, we're working on our spring schedule. One of the things we're looking at is bringing our volunteer department in to talk about opportunities for high school students to volunteer at MSK. And we're going to have a panel of students who have volunteered at MSK. And we're working on there are some folks who started as volunteers at MSK and now are working at MSK, including the head of the volunteer services at MSK who started as a volunteer here. So we thought it would be cool to share their stories and also to tell you about options to volunteer here. And we're working on some other ones. So we will send you an email. If you RSVP to this, we have your email address, and we'll be reaching out to you. So today's topic is very unusual. Astronauts in space undergo deconditioning. They don't bear weight, and so their muscles get deconditioned, and that is not good for them. And it turns out that cancer patients who are getting treated sometimes undergo similar deconditioning. And there are techniques that are being used for astronauts to prevent, and to lessen this deconditioning. And some of those might be relevant to people with cancer. The experts at that, of course, are at NASA. And tonight's speaker is somebody who worked at NASA. It's Dr. Jessica Scott. She's from Canada. She got her bachelor's, master's, and PhD in Canada and then did a fellowship at NASA. And she worked as a senior scientist in the Exercise Physiology and Countermeasures lab at NASA, which sounds very cool. We recruited her to MSK in 2017 to apply some of these techniques she's been using for astronauts to help our patients with cancer. And she's working with Dr. Lee Jones, who's an exercise scientist here. And his area of interest is looking at the toxicities, the side effects of cancer and its treatment, and seeing how specific exercise programs can be used to combat those side effects. So without further ado, I am honored and delighted to present to you Dr. Jessica Scott.
Well, thanks very much, Dr. Lieberman. I appreciate the opportunity to come and talk, and I'm excited to share with you some of the work we've done looking at exercise with astronauts and cancer patients, and a little bit about my journey, how I came to go from NASA to the oncology setting, which may seem very unique and disparate, but there's actually a lot of overlap. So I'm going to start with a little bit of history about NASA. Some of you may or may not know a lot about it, but it's gone under a lot of growth over the past 60 years. So the first human spaceflight was in 1961. It was a Mercury mission, and it only lasted 15 minutes, so it was very short. But since that time, there has been incredible progress in duration of spaceflight, and NASA is now looking at a 2.5-year mission to Mars. Our current era is the International Space Station, where astronauts are in space right now. They will be up there for anywhere from 3 months to about a year. And why it's possible to be in space for that long is because NASA implemented this Spaceflight Countermeasures program, and it involves two key things. It involves multisystem characterization and multisystem intervention. So today I'm going to briefly go through the evolution of the Spaceflight Countermeasures program, and then talk about how that is very applicable to what cancer patients are undergoing. And if you have any burning questions, please interrupt, please ask. We can have a lot of interactive time over the next 50 minutes or so. So in space, it's actually a very toxic environment. Back in 1961, after that very first flight, the astronaut experienced a lot of cardiac issues. He had orthostatic intolerance after just 15 minutes. So that's when researchers and clinicians understood that they really need to characterize what is going on when you send an individual into this very foreign environment. So NASA started characterizing all of these different systems, and we now know with longer duration missions, astronauts experience everything from cognitive impairment down to bone demineralization. And that's really because astronauts experience 3 key hits. So if we look at the first hit, it's a baseline risk factor. Most people think of astronauts are the beacon of health. They are the fittest, the healthiest, the strongest individuals. But this is actually not the case. So if we look back at the Pioneer missions, so those very first missions, the average age was actually pretty young, not compared to most of you, but it was 37. And what actually happened is that they were not that healthy. So this is a quote from a magazine I found back in 1959 that says, "In spite of their extraordinary qualifications, the astronauts have many of the preoccupations and even the small weaknesses of more ordinary men." So 2 of the 4 cigarette smokers in the group are trying so far unsuccessfully to stop, and 2 others were worried about their weight. So out of the 7 initial astronauts that were selected, 6 of them had a cardiovascular risk factor. If we fast forward to the current era, the ISS era, the average age of the astronaut is 49. They are typically male, and they typically have at least 1 risk factor, whether it's high blood pressure, high lipids, or they are overweight. So you take that individual who has a baseline risk factor, and then you expose them to the second hit, which is a direct hit, and that is microgravity itself. So on Earth, all of our blood pools in our lower body because of gravity. We've evolved for millions of years to be in this environment. And as soon as you launch in space and you get into microgravity, that is immediately removed, and about 2 liters of fluid move from your lower body to your upper body. So this is Canada's favorite astronaut, Chris Hadfield, and you can see on Earth on the left and in space on the right, his face looks very puffy, his vessels are distended in his forehead, and that's because of that 2 liters of fluid that has shifted from his lower body to his upper body. And you can imagine all of the physiological changes that occur as a result of all of those fluid shifts. And the third hit is an indirect hit. So these are factors secondary to microgravity. As Dr. Lieberman mentioned, they become very deconditioned. So this is astronaut Jeff Williams on the ISS in his typical position. So in space, the most comfortable position is a fetal-like position. So astronauts spend basically 24 hours a day in this position. There are no steps of daily living. They locomote using their arms, so you don't have any muscle activation. It's very little. And when they return to Earth, they are extremely deconditioned. There is typically a team of medical officers who will help them egress from the space capsule and carry them to the medical tent where they undergo a whole host of medical characterizations. And this picture really highlighted the deconditioning that astronauts experience. This is Scott Kelly after almost a year in space, and one of the medical team members had to help him hold up his arm because he was experiencing gravity for the first time, and he couldn't even hold up his own arm. So there's a whole host of measures that happen and physiological changes as a result of those 3 main hits. So back in the 1960s, NASA understood that there were these multi-system consequences, and they needed a tool that could assess as many systems at one time as possible. So they started giving astronauts, or having astronauts do what's called a symptom-limited cardiopulmonary exercise test. And this is where astronauts were placed on a bike. The load is progressively increased until maximal effort. So you go as hard as you can for as long as you can. The test is typically about 10 to 12 minutes long. And throughout the test, we collect expired gases. So you can see the astronaut has a nose clip, he's breathing through a tube, all of the expired gases go to a machine, and we get a value of VO2 peak in milliliters per kilogram per minute. So to give you an idea of some typical values of VO2 peak, we have endurance-trained individuals in blue. So if you do sports, you typically have a higher VO2 peak. If you don't do sports, you have a little bit lower VO2 peak in red. The highest value ever recorded was 92 in an Olympic cross-country skier. That's not even on this chart. And what we typically use for functional independence or to get a heart transplant is 15 milliliters of kilogram per minute. So if you're below this magical threshold of 15, that's when we know things are not looking so good. Now, the other thing to note about this graph is that as we age, there's a slow downward trajectory. So even if you exercise as hard as you can for as long as you can, this value still declines. So we typically lose about 10% per decade of VO2 peak. So how much do you think astronauts lost after 2 weeks in spaceflight? Any guesses? 5%? 10%? Yeah, so 25%. So astronauts in just 2 weeks, they lost about 25%. So 2 decades of aging in just 2 weeks. So at the time in 1964, this was pretty early on in the space program, but they were looking to go to the moon, and it was determined this is completely unacceptable toxicity to send a human to the moon. And they knew that they needed some kind of countermeasure to prevent that really significant decline. So this is where we come to this multi-system intervention, that second prong of the Countermeasures program. And if you go and look at all of the technical documents, which are really fascinating, from the 1950s, you start to get to an idea of how the clinicians were thinking of, should we give astronauts a pharmacological intervention? Should we give them a drug? And that was discounted almost immediately because they were worried about the side effects of drugs. They were worried about the gastro effects, they were worried about the sleep effects, a whole host of different metrics, and they had no idea how the drugs would react in a microgravity environment. So as you can guess, the intervention that they chose was exercise training. And they based it on this one paper from 1955 that was the first trial to actually train individuals. So there were a lot of cross-sectional studies where you look at trained people versus untrained people. This was the first study that looked at a pre and a post measure. And they found that exercise training improved cardiac function and muscle function. So from this point on, they decided, let's try exercise. Let's see if that works in space. So this is a picture of the very first exercise session performed in space. It was on a Gemini mission in 1965, so a 14-day mission. And the exercise device was a very simple device. It was a bungee cord, and they had astronauts pull on it as hard as they could, as many times as they could throughout this 14-day mission. This is not an easy task. If you can imagine, the Gemini capsule is very small. You are sitting in the chair that you are in right now, and the person next to you is your crewmate, and you're with that person in that space for 14 days. And you are expected to exercise on this bungee cord as many times as possible throughout the day. So it was not the most comfortable experience by all accounts, but it worked. So if we look at our 10 years of healthy aging, our 14 days of spaceflight without exercise, with exercise, the decline in VO2 peak was dramatically reduced. So it pretty much worked. And from that point forth, NASA's motto with exercise in space has been, rather than seeking permission to exercise, you have to get permission to be sedentary. So being sedentary or not exercising is not an option in space. So from 1965 until 2001, there were a significant amount of resources devoted to exercise, which is a little bit unusual when you look at what's happening here on Earth. But the majority of physiology resources were devoted to exercise. So there was a whole host of what exercise equipment should we use? What's the best prescription? So I'll fast forward through those years and get to the 2001 to 2009 when the International Space Station came online. So with the International Space Station, they developed new exercise equipment. So what astronauts were using back then and are currently using is what's called a T2 treadmill. So this is where astronauts are bungeed onto the treadmill, and they can perform running, they can walk. Of course, they have to be tethered to the treadmill, otherwise they would float away. And the other thing to note is that the device, if you noticed, it was shaking a little bit. So it's on what's called a vibration isolation system. And what they discovered very early on in one of the first exercise sessions, that where the treadmill was tethered to the space station, that as you're running, you can actually resonate the entire space station, and they were worried that the space station would actually go out of orbit because of that constant bouncing. So they had to very quickly develop this vibration isolation system where the treadmill is separate from the space station. So the other challenge was resistance exercise. We know that muscle atrophy is one of the major conditions that astronauts experience, and you can't just have any resistance exercise. The bungee cord is not an effective resistance device because it only has concentric motion. So when you do a bicep curl, that is concentric motion. You also want to have a load on the way down, and a bungee cord in space has no load on the way down. So the engineers needed to design something that could have both concentric and eccentric loading. And what they came up with was the Advanced Resistive Exercise Device. So this is Mike Fossum using the Advanced Resistive Exercise Device, or ARED, doing a squat. And the squat is one of the most important exercises for astronauts to do because their leg muscles atrophy so much. And what's unique about this system, again, it's on a vibration isolation, that's why it looks like a bit of an accordion, but it can be reconfigured to do basically any resistance exercise that you would on Earth, you can do it in space. So you can do tricep extensions, bench presses, lunges, calf raises, any exercise astronauts can do in space. Now the other aspect was looking at the exercise prescription. So astronauts did a very high volume of exercise. They were doing about 80 minutes per day, 6 days per week, at a pretty moderate intensity for the duration of their mission, which was typically about 6 months. So from 2001 till 2009, astronauts were using this program and this prescription. And I think there was the assumption that because astronauts were doing this high volume of exercise, it would be completely protective against decline in VO2 peak. Unfortunately, in 2009, there was a review of the data, and they found out that this was not the case. So astronauts were coming back after 6 months of spaceflight with about a decade of aging. And of course, despite this high volume, moderate intensity exercise, they still had this accelerated decline. And in 2009, we were looking to go to Mars. So again, NASA came at an impasse where there was this unacceptable toxicity for human missions to Mars. So what do? We've got this great exercise equipment. We've got this program that should work. Why is it not working? What do we need to do? So there was a summit with all the greatest exercise physiology minds to refine ISS exercise. And what they came up with was that, again, sticking with the characterization and the intervention, they needed to improve physiological monitoring and improve their exercise prescriptions. So that is back in 2009. And in 2010, this is where my timeline enters the NASA timeline. I was finishing my PhD at the University of British Columbia in Canada. And for my postdoctoral fellowship, I had two options. I had the option of going with Dr. Lee Jones, who was at Duke University at the time doing exercise oncology research, or I could go to NASA. My background is in cardiovascular physiology, exercise physiology, so there's these two fields that I could apply my tools to. Obviously, I went to NASA, and I thought I was saying goodbye to exercise oncology and working with cancer patients. So when I arrived at NASA, they were tackling these challenges head on. Their main task and their main goals were, how do we overcome these challenges so we can go to Mars? So what the standard practice in terms of physiological monitoring for astronauts was, there was a pre-measure and a post-measure, but they had no idea what was going on in between. And obviously, if you don't know what's going on in between, you can't intervene. So the goal was to do in-flight multi-system monitoring. So you could track astronauts as they were going, and if there was a decline, you could immediately intervene. Sounds easy enough, but it's not when you're in space and you're in this very unique environment. So one of the challenges that our lab was very focused on was, how do you quantify muscle size? Muscle atrophy was one of the biggest challenges and could be the main contributor to why astronauts were having this decline in VO2 peak. The gold standard of measuring muscle size on Earth is with a magnetic resonance imaging machine, which is very large, would probably take up this entire stage, but you get very nice images where you can quantify the cross-sectional area of all of these muscles and get an accurate description of muscle atrophy. In space, what they had was an ultrasound machine, and it's about the size of a laptop, so very reduced capacity compared to an MRI machine. But since my background had used a lot of ultrasound for cardiac measures, they said, well, you can figure something out to look at muscle. So the first area that we looked at was very simple. We just used muscle thickness. So this muscle here is called the rectus femoris. We put the ultrasound probe on the leg, and we thought, well, maybe we'll be able to get an idea of muscle thickness, of muscle atrophy if we look at thickness. So we had one of the astronauts, this is Mike Fossum. We got him to try it out over a few months, and what we discovered was that muscle thickness was a really terrible measure of atrophy because it was completely dependent on where you are along the leg. If you're a little bit closer to the knee, you get it completely different versus if you're an inch away. So we knew we needed a different tool. And at the time, there was some really important advances in ultrasound technology. So we decided to apply this panoramic imaging technique. So it's just like your iPhone. When you scan across a panoramic image, it will stitch the images together. So we tried that with ultrasound, and we got a pretty good image. So this is the femur, and then we can actually quantify, just like you would an MRI, this entire cross-sectional area. This is the vastus lateralis. So we were pretty excited. We thought we had discovered a solution to the challenge of muscle thickness. So on our next monthly call with Mike, we got him to try it. We said, try this panoramic image technique. Unfortunately, we kept getting images like this, where you can't see where the image is, they're all stitched together. So it's just like if you're trying to use your iPhone and you're not in the same plane, you don't follow your thread, you don't get a good image. And what he told us is that it's because it's very difficult to maintain a plane when you're imaging yourself. So again, we went back to the drawing board and we're like, okay, we need to figure out some way that we can keep the ultrasound probe in place and astronauts can just follow a guide like you have on your iPhone. So we went to Bed Bath & Beyond and we got a kitchen cutting board, one of those flexible kitchen cutting boards, and we cut slats in the kitchen cutting board. We MacGyvered some Velcro straps together so that you could strap it on your leg, and what we would our plan was just to put the ultrasound probe through this slat. And we tried it on Earth, and it worked beautifully. It was amazing. We got these very robust images that are very similar to what you get with MRI. So you can see the femur, the vastus medialis, rectus femoris, vastus lateralis, and vastus intermedius. And we can also use it on the calf to look at gastrec medialis and lateralis. And this is great because now we can quantify cross-sectional area in the muscle in space. So, of course, we can't send kitchen cutting boards to the International Space Station. So the engineers made much nicer ultrasound templates. So there are 3 different sizes on the leg and 3 different sizes on the calf. And astronauts can now just use this template on all of these different slices, and we can now quantify muscle atrophy. So how this works is this is Koichi Wakata, who is using our ultrasound template in space. One of the team members, this is me on we would usually go in at 2 o'clock in the morning and help the astronauts guide them through acquiring muscle ultrasound images. So this was one of the big successes, is now astronauts are using this to monitor muscle size in space while they're on their long duration missions. So that was one challenge that we successfully solved. The second challenge is exercise prescription. We thought that this high volume of exercise would be good enough to protect astronauts, but not all exercise is created equally. So there are different forms of exercise. And what was the standard is what's called a linear program. So you're working at a moderate intensity, typically about 70% of your maximal effort, and you do the same thing. So astronauts, every single time they would exercise, they would work out for the same time and the same intensity for their entire 6-month mission. It was very safe, there were no injuries, but it was not effective, as we knew. So at the summit, there were a whole host of different prescriptions that were proposed could be used. The first alternative, and one that was very popular, I'm told, was this high-intensity program. So many of you may have heard of these HIT exercise programs where you work out at 90%, 100% of your max, maybe in intervals. And this was one that is probably very effective, but there was questionable safety. So there was concern of whether doing this very high intensity bouts of exercise repeatedly for 6 months, whether some astronauts would get injured. So the second alternative is this non-linear exercise program. And this is where you could do higher intensity days followed by lower intensity days, and you progressively increase throughout your training program. And we know from athletes who have been using this for decades that it's probably safe, probably effective, and it adheres to the principles of exercise training. So NASA decided to go with this prescription. But before testing it in astronauts, they wanted it tested in an analog. So the analog that has been used since 1949 to simulate spaceflight is bed rest. And what NASA uses is a 6-degree head-down tilt bed rest. And we use the 6 degrees of head-down tilt because it simulates the fluid shifts that astronauts experience, and bed rest because of the deconditioning. So NASA commissioned this randomized control trial where there were 3 different arms. There was a diet alone group, a diet and exercise group, and a diet, exercise, and testosterone group. Now, this sounds very easy and very straightforward, just to move forward, but how do you get someone to exercise while they're lying down? This was one of the major challenges. How do you design exercise equipment to simulate what's going on in space? If you want it to be like space, you can't just have an individual stand up and start exercising. So we had to the engineers designed this horizontal squat device, again, to simulate the most important resistance exercise, the squat. This is my colleague Kirk, who is doing a pretty high load of resistance exercise, and it all in that horizontal motion. Now, an even greater challenge is how do you get someone to use a treadmill while they're in this head down tilt or supine position? So again, the engineers at NASA are amazing, and they designed this this device where our subjects would basically walk on the wall. So our subjects are in a harness, they're pulled into the treadmill just like astronauts are pulled in using a harness, and we can do our high intensity exercise and our lower intensity exercise all while maintaining that very important space flight-like environment. So the treadmill was a little bit unique, and we had to take it one step further to make sure that it was like what was going on for astronauts on the International Space Station. So we tested it in a parabolic flight. So this is where, this is also called the vomit comet, because this is what the parabolas look like to get microgravity. So it's simulated microgravity, but the planes go up at a 45-degree angle, and then they level off. So it's just like you're coming at the top of a roller coaster, and then you go down. And so we repeat that 40 times. So you can imagine doing that up and down 40 times. And you're also trying to get very important scientific information at the top of that parabola before you hit that hypergravity. So we were looking at ground reaction forces. We had ground reaction force data from astronauts, and we were seeing if it was similar. So it was. So we moved forward with the exercise program. And the next challenge is recruitment. How do you recruit someone to lie in bed for 10 weeks? Would anybody here like to lie in bed for 10 weeks? Okay, I have a couple of volunteers, okay. So most people do not find that an attractive option, and we were really struggling with how are we going to entice people to come and lie in bed for 10 weeks? But the media got a hold of it, and it went a little bit viral, the fact that NASA was paying people to lie in bed for 10 weeks. And the Europeans even went the extra step and had someone lie in bed with money to show that NASA was actually paying people to lie in bed. But this actually worked out really well because we had over 10,000 applicants for just 30 spots. So we actually had to deselect our participants. So what's unique about this study, and is probably one of the most unique studies I will ever participate in, is that it was basically like an animal study done in humans. So our subjects were monitored 24 hours a day by a person. So we had subject monitors who sat outside, again, not to break that spaceflight-like environment. Everything was done in the head-down tilt position, toileting, showering, eating, absolutely everything. They had a standardized sleep and wake schedule, lights out at 10, lights on at 6 a.m. Are you still interested in participating? The subjects got paid $18,000 they were with us for about 4 months. The diet was so tightly controlled that if subjects didn't finish an item from lunch, an item of isocaloric content was then added to dinner. We did a whole host of measures to make sure that they were in metabolic equivalent state. We monitored fluid intake and output. And the exercise prescriptions were monitored by 2 physiologists because the equipment was a little bit crazy and because we wanted to make sure that they were achieving their target zones that we had set out for them. So what we measured in the bed rest study was everything physiologically possible. And we did it at multiple time points. So we were interested in what is the trajectory of change in all of these systems. So for example, our participants underwent functional brain MRI imaging 7 times throughout the study, before bed rest, throughout bed rest, and then at the end of bed rest. And a whole host of organ measures all the way down to some blood-based genetic measures as well as muscle biopsies. So I'm not going to go through a lot of the results, and I'll refer you, if you're interested, to look up the papers that we just published this year. But the crux of the matter is that nonlinear exercise mitigated a lot of that multi-system toxicity. So this is the program that astronauts are now using on the space station. And if we look at the evolution of how NASA has continuously improved its exercise program and exercise prescription, it started way back in 1965 with this linear high-intensity program, which was only for these 14-day missions. In 2005, 2001 to 2009, they were undergoing 6-month missions, this linear moderate intensity. And today on the space station, astronauts are doing this nonlinear program for 6 months, still using this, what is now the optimal exercise equipment. So that's the very brief history of NASA's Countermeasure program. And I'll take you back to 2011, when I went to a conference called the American College of Sports Medicine. It's an exercise conference. So one of my very best friends was doing her postdoc at Princess Margaret Cancer Center. So she and I met up, and I was describing the multiple hit-induced multisystem toxicity that astronauts were experiencing and how we're using exercise to prevent all of that toxicity. And she said, "Holy cow, that sounds a lot like what my breast cancer patients are experiencing. They have chemo brain. They feel fatigued all the time. They don't feel well. It sounds exactly like what my cancer patients are dealing with." So that was a little bit of a light bulb that maybe I hadn't said goodbye to exercise oncology or working with cancer patients. So from 2011 till 2017, I was doing a little bit of collaborative work with Lee Jones, who was at Duke, but has since moved back here. And I reached out to him and I said, is there any way that we could still potentially collaborate? I know I'm at NASA, but maybe there is some distant work or virtual work we could do. And he's a very enthusiastic person, and he said, of course, let's do it. So for those years, we worked on a lot of review papers, and he really got me to understand what are the mechanisms underlying therapy-induced toxicity and how exercise could potentially mitigate a lot of those toxicities. So as we're doing all of these review papers, it was a little bit surprising that in a lot of other chronic diseases, exercise is standard of care. If you have heart failure, COPD, any of these other conditions, you are referred to an exercise program. And that is not the case in cancer. There is no standard of care exercise program in cancer. I was initially surprised by this, but really it's not that surprising. Because initially, when you were diagnosed with cancer, for many years, it was a terminal illness. You were diagnosed, and months or years later, you passed away. But in the interim, over the last 100 or so years, there have been significant improvements in the therapies and the screening techniques. So from the 1970s, where there were only 3.6 million survivors who had lived 5 years beyond diagnosis, now there are 16 million survivors in the United States, and that's projected to increase to 26 million individuals with a history of cancer by the year 2040 in the United States alone. So at the time, it seemed very poignant that there are these millions of individuals who could benefit from this NASA-like program. So the timing worked out, and as Dr. Lieberman mentioned last year, I joined MSK, and we're starting this Oncology Countermeasures program using a very similar approach that NASA uses, looking at multisystem characterization and multisystem intervention. So for the last remaining minutes, I'll go through a little bit of the evidence on what has been done looking at multisystem toxicity in cancer patients and the interventions. It's a very young field, as I mentioned, because there have been so many improvements in the treatment over the last 20 or so years. So when we're looking at multisystem toxicity in cancer patients, just like astronauts, the best tool we think is a VO2 peak. So we put patients on a bike, just like astronauts, or a treadmill. They do a VO2 peak test. And over the past few years, we've been looking at VO2 peak in cancer patients. So again, this graph shows 10 years of healthy aging, 10% per decade. And depending on the therapy, you get a very different response. So 3 months of anthracycline treatment for breast cancer, equivalent to 10 years of aging. And other therapies have an even bigger hit. So this is 6 weeks for bone marrow transplantation, which involves a very large hit, they lose about 2 decades of aging in just 6 weeks. So we know that there is this very big hit. Yes?
Can you talk a little bit about how you measure it?
Yeah, so we collect, so you have a mouthpiece in your mouth, your nose is clipped, so all of the expired gases are collected in this tube, and there's a machine over here, and that analyzes the oxygen content and the carbon dioxide content. So this part is open to the air, so you can still breathe, so you're intaking air, and all of the expired air goes into this tube, and it's called a metabolic cart, and that's what analyzes your ventilation, your expired air gases, and it gives us a value in milliliters per kilogram per minute.
O2 here means oxygen,
Yes.
and then V means volume.
Milliliters? Or sorry, what was?
So it basically measures the volume of O2.
It measures the volume of O2. Yes.
That's the only measure.
It's the measure, yeah, it's your measure of oxygen. So the question is related to how do you measure VO2 peak? So it's a volumetric measure.
Right. So it's basically the volume of O2 that you exhale.
Correct.
And the more it is, the better your
Correct.
condition.
The higher the number, the better.
Great. Thanks.
Yep. So if you remove your therapy, you would think that perhaps you would return back to your baseline level. But we know this is not the case. So this was a study looking at breast cancer patients 3 years post-therapy compared to a healthy control. And at every decade, if you had a history of being treated for breast cancer, you were significantly lower than age-matched controls. And even more concerning was that a 50-year-old breast cancer patient had an equivalent VO2 peak as a 70-year-old healthy control. So even years post-treatment, VO2 peak is still declined. And we know that this is prognostic in several settings. So in individuals who have metastatic breast cancer setting, there is an important improvement in mortality if you have a higher number. So you have a 41% reduced risk of all-cause mortality. And similar in lung cancer setting, the higher your value of VO2 peak, the better your outcome. So if we look at a summary of this multi-system toxicity, and we look at therapy as a bit of an accelerated aging, so cancer patients in pink, non-cancer in blue, we know that during treatment, patients experience a 10 to 20% decline in VO2 peak. It remains about 30% lower compared to controls. And long-term cancer survivors have a 20 to 50% increased risk of cardiovascular disease. So that's really why we're very interested in using an intervention. And it's a multi-system intervention like exercise because there's not a drug that can target all of these systems at one time. And we're interested in, can exercise increase exercise capacity, decrease cardiovascular risk factors, decrease cardiovascular disease, and morbidity. We don't know whether exercise works in the setting of cancer, and that's what we're very interested in. So I'll share this one study that we recently completed this year. This was an observational study. So that means we self-report what your exercise exposure is. So we just ask participants to write down how much exercise did you do over the last week. And this was in 15,000 adult survivors of childhood cancer. And this is a population that is at very high risk of cardiovascular disease. And we looked at all-cause mortality and some other factors. So what we found was that death from any cause was significantly reduced in those that reported a higher dose of exercise compared to those that reported zero exercise. And for the secondary outcomes, we saw that death from health-related causes was significantly reduced, and death from recurrence was reduced but not significantly. Now, as exercise interventionalists, we're also interested in change. So in a subset of participants, about 5,000 who completed 2 different questionnaires, we looked at what happens if you change your exercise exposure. So there were 4 different groups of individuals: those that maintained 0 exercise, those that decreased exercise, those that increased exercise, and those that maintained a high level. And what this graph essentially shows is that increased exercise or high exercise is associated with a 40% reduction in all-cause mortality. Yeah. So the question is, what do the question is, what are the n equal numbers? So this is the number of participants. So there were 5,689 participants who answered these questions at both time points. So exercise works if you in this self-reported setting. But we know there are some limitations. Not everyone tells the truth when you're answering a survey. Some people may over-report their exercise or under-report their exercise. So that's why randomized control trials are the best evidence of how you can determine whether exercise is having an impact. So we did a systematic review, and we found that there's really very little evidence looking at cardiovascular endpoints. But there was reasonable evidence that exercise can improve VO2 peak, and that's our primary metric that we're interested in. So we then looked at this a little bit closer, and we did what's called a meta-analysis. So this takes a whole group of different studies, and it combines all of the data together to look at the endpoint. So here we had 48 different studies for a total of 3,600 patients. The majority of these studies have been done in breast cancer patients. And what we can see by this little orange dot is that exercise improves VO2 peak when you look at all of these studies together. So that's great. It does look like exercise is having an effect. But when we did this meta-analysis, we started questioning, well, if exercise is so good, why is there a few studies that have a very big response, and then studies way up here, exercise doesn't look like it's working at all? Why is that? Is it the prescription? Is it the type of patients that are being trained? And so this is where we're trying to look forward a little bit more. Do we need to optimize the prescription? Do we need a different prescription depending on your different type of therapy? So this is a study that we're addressing this very question in. It's called the EXCITE study, and we're looking at breast cancer survivors 1 to 5 years post-therapy. And they're randomized to 3 different groups, just like our astronauts were. We're looking at the nonlinear program, the linear program, and there's a stretching control arm. And all of the sessions are supervised by our exercise physiologists just down the street. So as we wrap up and looking towards where we're going in 2019 and beyond, how do we move forward? We're very interested in what's called phenotyping. So we look at a whole host of different measures, just like we did in our bed rest study, all the way down from the gene up to the medical records. We can do some very fancy computational biology and combine all of these factors. We can then divide patients into different groups, and the goal is to deliver a targeted exercise therapy. So instead of giving one-size-fits-all exercise dose, we want to identify patients that maybe need this nonlinear program. Some patients may be okay with a linear prescription, and others may need a very high load of resistance training. We don't know, and this is what we're very excited about looking at now. The other area that we're interested in is precision exercise timing. So again, we've got our cancer-related trajectory across the diagnosis, therapy, and survivorship. If we start implementing a cancer countermeasures program trajectory before they start therapy, during therapy, and then again after therapy, can that optimize outcomes for cancer patients? Now, the question we often get is, that's great, but how do you implement that? Patients need to come and do a supervised exercise session 3 days a week at our site. That's not very feasible. So we've started our tele-exercise therapy, where we deliver treadmills to patients' homes. And our exercise physiologists are at our exercise oncology mission control, which is Kimmel just down the street. And we use Skype or a Jabber to just do a virtual training session. All training sessions are supervised, but we can do it in the convenience of a patient's home. So in summary, what we know is that spaceflight and cancer treatment cause very similar multisystem toxicity. The mechanisms are certainly different, but the intervention could be very effective. The same, which is exercise. Exercise mitigates that multisystem toxicity, but right now, one size of exercise likely does not fit all. So my final slide is a little perspective. This is astronaut Harrison Schmitt, one of the last astronauts on the moon. Earth is this tiny dot, millions of miles away. And a quote that Vice President Biden said that I love, it says, "Break down silos and bring all the cancer fighters together to work together, share information, and end cancer as we know it." And MSK has done a fantastic job of doing just that, bringing together very disparate groups and working together and breaking those silos so that we can understand and move the field forward. So thank you very much, and I'd just like to acknowledge my collaborators, Lee Jones, Chow, Anthony, and collaborators at Johnson Space Center. So thank you very much.
Thank you for a fantastic talk. We have time for a few questions. I would invite you, if you want to ask a question, either to step to the standing mics, or Andrea and I can run around with microphones and see if we can maximize our VO2 peak by running to you to get you the microphone in time. Are there any questions? Yes, hold on, Andrea is coming. She has an outstanding VO2 peak.
So what kind of exercise do they do? Is it just weightlifting? Is it just running? Is it a combination?
Do the astronauts do, or
the cancer patients?
Right now it depends on what type of therapy they get and what their limitation is. So for breast cancer, they get a lot of treatment that is toxic to the heart, so we do a lot of aerobic exercise. For a lung cancer patient, for example, they have a lot of muscle atrophy, so we'll do a combination of resistance and aerobic. So it's very dependent on the population. Again, we're trying to get away from one-size-fits-all prescriptions and target it to what the patient needs, just like oncology is doing with their drugs.
Thank you.
When you talked about like the breast cancer patients and like there was a type of treatment, I don't know if I'm going to pronounce it correctly, but it was like anthracycline. What exactly is that?
What is anthracycline?
Yeah.
So it's a drug that will target the tumor itself, and it's a systemic drug. So patients will go in, and it's called doxorubicin. There are different forms of anthracyclines, but they'll typically go in and have an infusion, and the drug goes in, and they'll be getting an infusion for anywhere from 1 hour to 2 hours, and they'll come back and do that repeatedly over many months.
What are like the effects of that kind of treatment?
There are a whole host of different effects. So the good thing about the drug is that it will target the tumor, but it also targets a whole bunch of other cells. So that's why breast cancer, if you do have an anthracycline treatment, you can have heart troubles because anthracycline also targets some receptors on the heart. And you get other side effects like it's called peripheral neuropathy, so you start feeling tingling in your hands and your feet. So there's just a whole host of other symptoms, and it's very patient dependent.
I just wonder why so many of these studies seem to have been done in breast cancer survivors.
I think that is one population where very early on anthracyclines were successful and patients were surviving longer. So that's where a lot of exercise interventions started happening. The first one was back in 1988 because patients were faring very well with both the treatment and the longevity. So I think that's a population that is both at risk and they're amenable to having these interventions. But we know now with all whole various forms of cancer and their treatment, they're getting better. Patients are living longer, so we need to expand the interventions beyond just breast.
So is the VO2 loss reversible for the astronauts that come back, or?
Excellent question. So it is, but you have to work at it. So if you didn't work at it, it would just continue on that decline, just like it would with cancer therapy. So what we do with astronauts is that the day that they land, they land in Kazakhstan, and they are then carried to the medical tent, and they are immediately loaded onto an airplane and flown back to the United States. So typically we would test them 24 hours after they landed. They would come to Johnson Space Center. We would do our VO2 peak test, our muscle tests, our heart tests, and then the next day they would start their exercise rehabilitation program. So it was almost as soon as possible we would get them exercising. And again, it was very individual on how long it would take. Some astronauts didn't lose any, so they didn't have a lot of rehabilitation to do. Others, it took a month to get their VO2 peak back to their baseline level. But it would continue until they got back to baseline. And that's just one system. So the bone takes a lot longer to rehabilitate, so bone will take months to get back to their baseline level. So the exercise program continues all the way until all systems are back up to that baseline.
So during the lifetime, can astronaut go back to space a lot, or only like once in their life?
There have been several astronauts that have gone back numerous times. The major limiting factor is their radiation dose. So as soon as you go into space, you get much different radiation than what you have on Earth, and you're exposed to different types, so solar particles, and they all wear radiometers to look at what the radiation dose is, and as long as you're below a certain threshold, I'm not sure what it is, but you're allowed to go back into space. I think the most there have been a few that have done both shuttle missions, so those are shorter. They were typically 2 weeks. So they've done several shuttle missions and then gone back and done, I think, a maximum of 2 ISS missions. That's the most I'm aware of.
Thank you.
I was just wondering, is it possible to get cancer in space?
That has not happened, but I'm sure it's very possible to get a new diagnosis in space. But astronauts are very heavily screened before they go into space. So if there is any hint, they will not be allowed to go into space. But if we start going on these very long duration missions to a year on the International Space Station or to Mars, I'm sure it is very possible that could happen. I'm not sure what they would do because we're not flying any pharmacological interventions. There might be surgery is possible. There was on Antarctica in the South Pole, there was a physician who found a lump in her breast, and she did a lumpectomy herself. So that is possible that something like that could happen, but hopefully that never happens.
I wonder what it was like being a woman at NASA.
It was the majority of the individuals that I worked with was a very big mix. So because the engineering field is very heavily skewed towards men, we didn't have that same skewedness. We were in the life sciences department, so it was very well balanced between the male and female, and there was no issues with any gender imbalances or anything.
And did you work with any female astronauts?
Yeah, so the astronaut core is primarily male, so it's about 80% males. But we had, when I was there, we only had 2 female astronauts that flew. And so that was over a 6-year period. There was only 2 female astronauts that we worked with. So any females out there who are interested in space, I encourage you to go become an astronaut, because it is very underrepresented in the astronaut population is females.
You didn't think you were going to come to MSK and be encouraged to become an astronaut, right? Any other questions? Okay, well, thank you for a fantastic and eye-opening
Thank you.
talk. Thank you so much.